like to next introduce Dr. Derek Serna-Gallegos, Assistant Professor of Cardiothoracic Surgery, a great colleague, talented thoracic surgeon. Had the pleasure of working with him a few weeks ago. We did a unique endovascular case, and I'm looking forward to his presentation this morning. Thank you.
Thanks a lot, Mike, and thanks to all the directors that put all this together. It's been great so far, and I appreciate you inviting me to be involved. Today's talk is mostly going to be about some of the overall general goals of endovascular therapy. We're going to talk about strategies for addressing complexities, mostly of the aortic arch. I mean, I think most of the talks today have kind of shown that gold standard for descending thoracic aorta is really going to be TEVAR, and where we're kind of expanding, endovascular therapy is going retrograde into the arch, and obviously from Dr. Estrero's talk and some of the other talks from Dr. Singh going down into the abdomen also. But this talk is going to be a little bit about going back towards the arch. Overall, the goals for endovascular therapy can be divided a little bit between whether you're trying to treat a dissection or an aneurysm. And just like with open therapy for dissections, we want to deal with the intimal tear. With open therapy, you're cutting out the tear, replacing it with a graft. With endovascular therapy, we're really trying to cover that intimal tear and in effect correct the malperfusion that can be associated with aortic dissection. We also want to deal with aortic remodeling, meaning obliteration of the false lumen and reconstitution of the strength of the wall of the aorta. Aneurysms, the goal generally is to exclude and depressurize the site of the aneurysm. You need a good proximal and distal seal, and as we'll see, this can be a little bit of a challenge in the aortic arch. So kind of as I said, the gold standard really for descending thoracic aorta, now is dealing with it with endovascular means, meaning a TEVAR. But when we talk about the arch, there's no kind of gold standard endovascular approach right now. So the discussions are really sternotomy versus, in some situations for the distal aortic arch, thoracotomy. And then, right now we're going to be discussing the endovascular options and kind of moving forward. Some of these considerations that we all have to think about, when we talk about the aortic arch, obviously the branch vessels and malperfusion to the brain and to the upper extremities. We got to deal with the curvature of the arch, which is something we don't have to deal with as much when we're talking about doing TEVARs and work on the descending thoracic aorta. There are some challenges also related to just the distance from the femoral access site. So we're talking about a much further distance, and we're also talking about dealing with the curvature of the distal aorta. There's a challenge that comes with having multiple access sites. If we're dealing with the branches of the arch of the aorta, we may have to be looking at access sites of the innominate and right common carotid artery, as well as the left common carotid and sometimes the subclavian artery. The other thing we deal with more is that precision is of utmost importance everywhere, but it's particularly important when we're talking about the arch of the aorta, when a mistimed cardiac cycle can lead to misplacement of a graft and possibly malperfusion of one of the branches of the arch of the aorta. So it is something that's incredibly important, and for that reason we typically use ventricular pacing to try and decrease the cardiac output and allow for more precise placement of the grafts. So I think a lot of us that are involved with aortic surgery really enjoy kind of the strategies of dealing with a problem. And when we're going through training, we're kind of conditioned to think there's one way to treat one thing, but as we move on and develop a better understanding, we realize that obviously there's a lot of ways to skin a cat, and that's one of the great challenges of aortic surgery is being able to think on the fly and deal with multiple problems in multiple different ways. And as far as dealing with the arch, there's been different descriptions of hybrid repairs and then also total endovascular repairs, and we're going to quickly talk about both strategies. Hybrid repair involves open reconstruction to create the proximal landing zone, the kind of generalized goals of endovascular surgery, that proximal and distal landing zone. As we talked about the difficulties in the aortic arch, there are ways to create the landing zone that we need. So open reconstruction to create this proximal landing zone for the placement of an endograft. And this has been discussed, this publication was from the University of Pennsylvania, but this was discussed previously and looked at 3 types of hybrid repairs. There's kind of 3 different, I guess, strategies for achieving the same thing. In type 1 repair, this can be achieved without cardiopulmonary bypass, theoretically, and without complete clamping of the ascending aorta. This involves debranching of the vessels of the arch and placement onto the ascending aorta, and then deploying a stent graft throughout the entirety of the arch. This can be done without complete cross-clamping of the aorta. It can be done theoretically without cardiopulmonary bypass and without the need for circulatory arrest. Type 2 involves complete cross-clamping of the aorta, even if it's for a short period, and replacement to the ascending aorta to create a position where you can sew on that trifurcated graft that goes to the arch vessels. It also provides a larger landing zone if the aneurysm extends into the distal ascending aorta, a landing zone for that endovascular graft. And then type 3 is kind of our typical open repair of a total arch replacement, obviously using a graft to replace the entire arch. This would require, obviously, cardiopulmonary arrest, or cardiopulmonary support and circulatory arrest. There are certain challenges to this hybrid repair, the main one being that you still, it requires a sternotomy. In some cases, it requires circulatory arrest. In some cases, it requires cardiopulmonary bypass. Many of the things that you're trying to avoid with using an endovascular repair, because some of these patients may be higher risk and not able to tolerate all of that. In my opinion, a lot of these, you accept the risks of open repair, meaning basically a sternotomy, cardiopulmonary bypass, plus minus circulatory arrest, but you also accept some of the downsides of endovascular therapy, meaning that you can still have a type 1 endoleak, you can still have retrograde dissection in a situation where you're not replacing the ascending aorta. So you in effect, kind of accept the disadvantages of both open and endovascular therapy. It's important to also realize there is significant morbidity and mortality. The literature described mortality as high as 9.5% to 12%, with stroke rates up to 7.5%, and irreversible spinal cord ischemia of around 5%. Obviously, there is some bias on these patients being sicker patients, and we have to, hold this up to not necessarily a gold standard, but what's a standard operation, meaning total arch replacement. With this meta-analysis showing mortality of about 5.3%, neurologic deficit, a permanent neurologic deficit of about 3%, looking at 2,800 open patients. So, when we're looking at things like hybrid approaches and stuff like that, we really have to look back and see what we're comparing it to. Obviously, you got to compare the patients, and it's hard to do that well, but it's just something that we have to think about. If we start to look at total endovascular repair, theoretically this strategy would avoid some of the pitfalls of open and hybrid repair. I think doing a sternotomy on certain patients is not insignificant, and even if you're able to avoid cardiopulmonary bypass, or you're able to avoid circulatory arrest or clamping of the ascending aorta, there's still significant morbidity that can be associated just with the performance of a sternotomy. Total endovascular repair theoretically would allow for adequate proximal landing zones and improves remodeling of branch vessels if they're involved in the dissection. So we obviously want to improve the remodeling of the aorta, but if we can do that also for branch vessels, that we believe that there is some advantage to that. These are some of the graphs that over the years have been developed. the Relay Plus, which is a double branch device, the Gore TAG or TBE device, which is a single branch, the Zenith fenestrated device, and then the Nexus device, which includes an ascending aortic portion of the graft. The Gore device is FDA approved. Let's see what I'm doing here. This was a early feasibility study that looked at zone 2 deployment. So if you have, going back to kind of the strategy of this, you have three branches of a normal aortic arch. And, you would think, well, I need three different, branches to an endograft that's going to go through that arch. But the truth is we can do significant manipulation of the vessels, both the subclavian, the left subclavian, left common carotid, and right common carotid arteries to make that so that you don't need a three-branched endograft. This was 22 patients that they looked at feasibility of using this graft placed in zone 2, so just going into the left subclavian artery. There was no strokes, and one episode of spinal ischemia that resolved. It was really spinal paraplegia, not paraplegia, but resolvable ischemia. You can do significant kind of vascular gymnastics, I guess you could say, to be able to have one branch that supplies the entire branches of the arch of the aorta. And in this case, this study looked at 9 patients, and they were able to perform subclavian to carotid bypass and then carotid bypass, use a single branched this Gore graft, and be able to cover the entire arch of the aorta. So I think, strategically, one branch theoretically can be enough, and not theoretically, it can be enough. And this device turned out to be a good device. The one situation going back, let me go back one slide. One of the downfalls, I guess, of trying to manipulate not just the left subclavian, but as you go more proximal into the arch, into zone 1 and zone 0, is that the stroke rates had gone up. In this study, there was only 9 patients, and 3 of them had type 1 endoleaks, and I think 2 of them had strokes at 12 months. So, as we manipulate the arch vessels more and more, we do see, we have seen an increased rate of stroke. This is a dual branch graft that's from Terumo. It's currently recruiting in efficacy trials. It requires left common carotid and right common carotid access, and then either a bypass of the left subclavian artery or a transposition. There's 2 antegrade tunnels, a wide fenestration, and you're able to use 2 branches. This is kind of a schematic of how it's deployed. Initially, you have to do some sort of either a bypass or a transposition of the left subclavian and left common carotid. You get wire access of both the right and left common carotid arteries. You deploy the initial aortic graft and then access the fenestration, and you're able to put graft up into each the vessel, meaning the innominate and left common carotid. This was just a schematic, or not a schematic, but an actual patient after this was deployed. The Nexus is another device that's currently recruiting for feasibility studies. The difference, I guess, in the strategy of this device is that it also goes into the ascending aorta. So it's a single branch device. It would require, left subclavian to left common carotid and then carotid bypass. But it theoretically, it would also address some ascending aortic pathology too. So where do we go from here? Right now, a lot of these devices have not been put in a lot of patients. We do have some data, although very small, looking at how these patients do, but we do need to establish durability with ongoing follow-up. We need to evaluate the outcomes for various strategies, and we need to increase the sample size of patients who get these devices. I think the technology is very promising, and the way that it's been used throughout the abdominal aorta, the descending thoracic aorta, I think it's very promising that a lot of these results can be replicated in the aortic arch. We do need to also differentiate the utility in different circumstances: acute dissection, chronic dissection, aneurysm. We all, appreciate the differences in these circumstances, and we know that differences in how these patients present really leads to different outcomes. So we want to make sure that the technology addresses each of these different circumstances, and that going forward we really try and do exactly what's best for our patients. Thanks again to the directors of the meeting, and thanks for inviting me.